Hello, I'm Steve Hauser. I'm the president-elect of the American Heart Association, and I'm here with Dr. Mark Creager, who's the president of the American Heart Association. And we'd like to review some of the clinical trials that have been presented here at ACC, and I'm going to ask Mark if he would start us off and tell us a little bit about what he thinks are some of the great new things that are happening here in the clinical research world.
So, Steve, it has been an interesting meeting here in Chicago. There were a number of important clinical trials that were reported, some showing positive outcomes and some negative outcomes, as you might expect. Two in the cardiac surgery area I'd like to speak about. The first was the long-term follow-up of the STITCH trial. And STITCH trial was for patients who had coronary artery disease that was amenable to coronary artery bypass surgery and an ischemic cardiomyopathy. So they were randomized to CABG or not. And it turned out that those individuals who underwent coronary artery bypass surgery had less cardiovascular events during follow-up. They had decreased total death and decreased total death plus decreased hospitalization for cardiovascular causes. So very interesting. The second cardiac surgery trial that I wanted to talk about was sponsored by the NIH's Cardiothoracic Surgical Network. And this trial was examining the effect of mitral valve repair in individuals undergoing coronary artery bypass surgery who had ischemic mitral regurgitation, moderate mitral regurgitation. In the group who underwent mitral valve repair over a period of 2 years, there was less severe mitral regurgitation. But there was really no difference in cardiovascular outcomes in terms of mortality or hospitalizations for cardiovascular causes. So two very interesting cardiac surgery trials, which I think will affect our practice moving forward.
So Mark, there was one study that addressed post-myocardial infarction remodeling and the possible effects of beta blockers in that setting, and I thought you might tell us a little bit about that.
Well, that's been a long-standing question, the efficacy of beta blockers in patients with coronary artery disease and how long you give it. But this particular trial, the BAMI trial, looked at the potential efficacy of early administration of intravenous beta blockers, in the case metoprolol, on myocardial infarct size as assessed by magnetic resonance imaging at a period of 30 days post-infarction. And these individuals all underwent PCI for their ST segment elevation myocardial infarction. It turns out that early administration of intravenous metoprolol prior to the PCI did not affect myocardial infarct size. There was a decrease in the incidence of malignant arrhythmias, but the primary endpoint was no different between the two groups.
So Mark, could you tell us the final results of the Partner 2 trial?
So that was another interesting trial that was presented. So Partner 2 is a comparison of TAVR with surgical AVR in patients who have severe symptomatic aortic stenosis but are at intermediate risk. Intermediate risk characterized by an STS score of 4 to 8, yet these patients were pretty frail. Nonetheless, comparing the two groups, there was no difference in total death or in major stroke in the groups as a whole. But if you break down the TAVR group into individuals who had transfemoral access versus those who had thoracic, primarily transapical access, there was a difference when compared to surgical AVR. In fact, the outcomes were better in the individuals who underwent TAVR who had femoral access than those who had surgical AVR, but they were not in the individuals who had transapical AVR. And in part, they're a different substrate. There's more difficulty accessing them because of more diffuse atherosclerosis. So perhaps that outcome is not so surprising. But it does really reinforce the role that TAVR is playing in the management of our patients with severe aortic stenosis.
There was an interesting electrophysiology trial that was released called Fire and Ice, and could you tell us a little bit about that one?
Well, Fire and Ice, right? It actually implies what the trial was about. This was looking at patients with paroxysmal atrial fibrillation refractory to medical management who were randomized to one of two types of ablation procedure: radiofrequency ablation, fire, or cryoablation, ice. And the endpoint was looking at resolution or prevention of recurrent atrial fibrillation. It was a non-inferiority trial. In fact, the two treatments were comparable in that regard. One was not non-inferior to the other.
We both listened to the results presented on the HOPE-3 trial, and I thought you might tell us a little bit about that trial too.
Well, the HOPE-3 trial, which really had three components. So HOPE is the Heart Outcomes Prevention Evaluation trial, and this was the third trial in that series, was a primary prevention trial. And it had several components to it. So the individuals who were enrolled were men over the age of 55, women over the age of 60, who had at least one additional cardiovascular risk factor. So they would be considered at intermediate risk for future cardiovascular events. And the two components were a blood pressure lowering arm, which was candesartan 16 milligrams a day plus hydrochlorothiazide 12.5 milligrams a day versus placebo. And then there was a lipid lowering arm with statin, rosuvastatin 10 milligrams a day versus placebo. So there was three components to this trial presented. One was the blood pressure lowering arm, one was the cholesterol lowering arm, and then the other was the two together versus placebo. The first, the lipid lowering study with rosuvastatin showed that treatment with a statin for primary prevention in these intermediate risk patients reduced the primary composite endpoint of cardiovascular death, myocardial infarction, and stroke. In the blood pressure lowering trial, there really was no significant difference in the primary composite endpoint. Now, candesartan and hydrochlorothiazide in combination compared to placebo lowered systolic blood pressure about 6 millimeters of mercury. But what was interesting, if you break that trial up into the baseline blood pressure, the tercile with the highest blood pressure did have a benefit in cardiovascular outcome, whereas that benefit was not realized in those in the middle and lowest tercile. And then putting it all together, so taking those individuals who were treated with rosuvastatin, candesartan, and hydrochlorothiazide, compared to those individuals who just got placebo, there was a benefit. But the major component of that benefit really was mediated by the statin arm.
So Mark, the HOPE-3 trial was conducted in a very diverse population of patients throughout the world. So how do you think that might impact how we treat patients with moderate risk of cardiovascular disease moving forward?
Well, actually, it's an important question. That's why the trial was done. So the beauty of this trial is that it was a multinational trial, and it really included a very diverse population. So that statin therapy in this population at intermediate risk is effective. And you know, these findings are really fairly consistent with our 2013 ACC, CDC guidelines on cholesterol lowering, identifying patients in intermediate risk, and recommending the use of statin therapy. So I think that reinforces that and extends it somewhat. The blood pressure lowering arm is also important. What it certainly suggests is that those individuals with high blood pressure do benefit from blood pressure lowering therapy and reducing their cardiovascular outcomes. Now, how that will be integrated with other recent trials like the SPRINT trial in our guideline recommendations, we'll wait the opinion of our writing group, but I'm certain that they'll be taking this information into consideration as they formulate those recommendations.
So Mark, can you tell us about the ACCELERATE trial?
The ACCELERATE trial was another in a series of trials that looked at cholesterol ester transfer protein inhibitors in patients with dyslipidemia. And this one in particular looked at evacetrapib. And evacetrapib did as it was anticipated to do. It lowered LDL cholesterol by 30% and raised HDL cholesterol by 130%. But in spite of those favorable effects on the lipid profile, there was no benefit in terms of cardiovascular outcome. So we've now seen trials with 3 cholesterol ester transfer protein inhibitors, torcetrapib, which was a negative trial. In fact, outcomes were worse with torcetrapib, with dalcetrapib, and now with evacetrapib. And in all these trials, benefit is not being realized. So despite our optimism of seeing improvement in cardiovascular outcomes by raising HDL and lowering LDL concurrently in patients with dyslipidemia, those hopes were not realized. There is one more trial that's still taking place with anacetrapib, and that'll be reported out in the near future. We'll see what that one shows.
So Mark, some very interesting clinical trials with some positive and some negative outcomes. Obviously, there's a need for more work so that we can develop the therapies that patients need to help prevent cardiovascular disease and stroke. So could you comment on the AHA's approach to making progress in this area? Absolutely,
Steve. So we're all delighted that we have been making progress, but there's a lot to learn. So the American Heart Association has put together strategically focused research networks, and these strategically focused research networks integrate centers into a network to study particular theme areas. And that would include prevention, that would include high blood pressure. And our centers are looking at basic science, they're looking at translation of that basic science, and they're looking at application in a population-based model. So I think that the knowledge that we'll gain from the strategically focused research networks will add to our science base and enable us to develop more effective therapies to prevent cardiovascular disease.